So thank you firstly for inviting me to come and speak today. I'm a pediatric endocrinologist working at Cincinnati Children's, talking about the endocrine system and charge syndrome. I've got no relevant disclosures. So today, the outline of my talk, firstly, I'm going to talk about what is the endocrine system. Secondly, what are the endocrine issues that people with charge syndrome face? And thirdly, what can we do about them? And I'll also introduce you to one of my patients here, Adam, who some of you may know. And I would say that he has taught me a lot of what I know about charge syndrome today. So first of all, what is the endocrine system? Basically, it's a system of glands and hormones in the body. The hormones are very important for various functions in the body, such as growth, development of the genitals, puberty development, bone health, and other functions. And as many of you will see, these are all very pertinent issues for people who have charge syndrome. The endocrine system really starts off in the brain, and there's a master gland in the brain called the pituitary gland, and the surrounding area called the hypothalamus. And these secrete hormones that actually travel to other glands in the body as controlling hormones, and they stimulate these glands in the body to make downstream hormones, which in turn bring about the actions that the endocrine system is trying to do. So for example, the pituitary gland makes the hormones that control puberty. These are also very pertinent for people with charge. You can see here the hormones that control puberty that come from the pituitary gland. And these stimulate the ovaries in girls to make downstream hormones, estrogen and progesterone, that bring about the findings that you typically associate with puberty. And in boys, these hormones stimulate the testicles, which in turn make testosterone that bring about the puberty changes in boys. The pituitary gland also makes growth hormone that's important for growth, hormones that control the thyroid gland, and also hormones that control the adrenal gland that make cortisol. So what about the endocrine system and charge syndrome? And all of you are familiar with this acronym, which I don't really have to go through, but I just wanted to highlight that this acronym contains the R and the G of charge. So R stands for retardation of growth and or development, and the G stands for genitourinary malformation, and these really encompass the majority of the endocrine issues that people with charge syndrome experience. In addition, many of you are familiar with some of the diagnostic criteria, and so I just wanted to point out in one of the older criteria, cranial nerve dysfunction is listed as a major criterion, and the nerves that control the sense of smell are very tightly linked in with the nerves that secrete the hormones that control puberty. In addition, the minor criteria for that particular classification include genital hypoplasia or underdeveloped genitals, including micropenis or small penis, and cryptorchidism, undescended testicles, as well as delayed puberty. And finally, that particular set of criteria also includes growth deficiency. A more recent diagnostic criteria from 2005 as part of a minor criterion includes the hypophyseal dysfunction. What that means is hypothalamo relates to the hypothalamus, the area surrounding the pituitary gland. The hypophyseal means pituitary, and dysfunction means dysfunction. So basically, people who have charge syndrome, one of the minor criteria says that they have dysfunction of the hypothalamus and pituitary, master controlling areas of the endocrine system in the brain. So we're familiar with the fact that the culprit of charge, where there's a change in the gene of CHD7, very important for bringing about the changes in the body when the baby is developing in utero. When we don't have that functioning properly, it's also very important for the development of the nerves that control the sense of smell, as I mentioned. And those nerves that control the sense of smell are, as I mentioned, very tightly linked in with the nerves that make the hormones that control the whole puberty system. In addition, anything that goes awry with CHD7 is also important in terms of affecting the development of the pituitary gland and the surrounding hypothalamus. So endocrine issues are actually quite common in CHARGE syndrome, but as Dr. Wiley said, sometimes they may get pushed aside because of some of the other more pressing issues. Most people who have CHARGE syndrome have short stature, and a small proportion of those have growth hormone deficiency. Again, most people who have CHARGE syndrome have something called hypogonadotropic hypogonadism, which basically means low levels of the hormones controlling puberty and underfunctioning of the gonads. And this can lead to genital underdevelopment as well as delayed or absent puberty, and later in life may have implications for fertility. Other pituitary deficiencies that have been reported in people with CHARGE syndrome include structural pituitary abnormalities in a few, low thyroid in a few, and adrenal insufficiency in a few. And then not to forget about bone health. We don't really know the prevalence of low bone health in people with CHARGE syndrome, but we do know that the hormones that control puberty are very important for ensuring that we have strong bones. So I was curious, just thinking about this talk, are all people with CHARGE syndrome getting endocrine care? And this was from a recent study in Canada, and a study of adolescents and adults. And it was interesting to me that in this study, that despite most people having some endocrine issues, fewer than half had actually seen an endocrine specialist. It was also interesting to me that in this patient population, the endocrinologist was the second most common medical specialist after the ENT doctor. And then also, despite most reporting a history of delayed puberty, only about half of these patients had tried hormone treatment. What about our patients? And these are really rough numbers. Again, I was just curious, how many patients do we see here in Cincinnati? And over the past year, 40 children with CHARGE syndrome were seen by the endocrinology division at Cincinnati Children's. And a little over half of these were patients from the CHARGE Center, so that would include some of you and many people from out of town. The remaining were local. And then looking at these numbers a slightly different way, of those patients who are registered as part of the CHARGE Center, how many had actually seen endocrinology here at Children's? And about 1 in 5 of those patients who were registered with the CHARGE Center were seeing an endocrinologist here at Cincinnati Children's. Now, these numbers, of course, don't include many of you who see an endocrinologist close to home, so it's by no means trying to imply that people are getting less care for their endocrine issues. But it does beg the question, where are we in terms of endocrine care for people with CHARGE syndrome? Are we inactive? In other words, are we not seeing an endocrinologist at all? Are we reactive, seeing an endocrinologist perhaps when we really have to, when those issues become really pressing? Or are we proactive, monitoring and instituting hormone treatment on time if indicated? And I would imagine that most of you in the room are very proactive in your care, seeking multidisciplinary, comprehensive care just by virtue of the fact that you are here. However, I still ask the question, how many of you are actually seeing an endocrinologist? Is that comprehensive care including endocrinology for everybody? Or, as Dr. Wiley implied, is endocrinology a little bit pushed to the side just because of the overwhelming number of complex issues and more pressing issues that we have to face with our children. So coming back to Adam, this is Adam around about the time that I met him when he was about 2 years old. And Adam has Charge syndrome. As you can see, he has a long list of many of the features of Charge syndrome. You can see his tracheostomy tube there, just to prevent aspiration of any of his feeds into his lungs. In terms of endocrine issues, so at birth, Adam had a small penis and he had undescended testicles. When I saw him around the age of 2, he was short, growing slowly, and subsequent testing actually revealed that he had growth hormone deficiency. He'd had an MRI of his brain, and that showed that he actually had a small pituitary gland that didn't look normal. And there was a question about whether he might have adrenal insufficiency. As a little boy, when he was about 6, he was diagnosed with low thyroid hormone, and currently he's about 13 or 14 years old, and we're monitoring what's happening with his puberty. So this takes me to the specific issues, starting with the R in Charge syndrome, retarded, or I don't really like that word, slow growth. So what is typical growth? And here you can see on the left a blue growth chart and on the right a pink growth chart. And those lines symbolize how most children are typically growing if they're healthy, across from age 2 up to age 20. What happens if growth is not normal? So some of the terms you'll have heard would be short stature, and this means that height is below the bottom of the growth curve for either normal boys or girls. Or slow growth, or growth failure. This is when somebody might be growing in height, falling away from their curves. So they might be on the growth chart, they might be below the growth chart, but they're not growing parallel to the growth chart. They're falling away over time. What happens to the growth in Charge syndrome? So at birth, reports suggest that birth weight and birth length are within the normal range or may even be in the low normal range. And you can see here, this is a graph from 0 to 2 years old for people with Charge syndrome. And you can see at birth, at the top, length being in the middle of the normal range, although there's a little bit of a range, and weight being in the low normal range. During infancy, and really this can be within the first few weeks to months of life, growth slows down. So once again, you can see here that the height seems to be starting to fall below the line that it was on. And then over time, even before the age of 1, the average height was below the bottom of the normal range. And for weight, you can see a similar pattern as well, where this dotted line represents the bottom of the normal range for length and weight. During childhood, children with Charge syndrome remain short, but there may be an improvement in their growth rate, but they still remain way below the curve. And then in adolescence, this also depends on whether puberty is kicking in or not. What are the causes of poor growth in Charge syndrome? Well, the minority are probably due to growth hormone deficiency. Feeding problems, poor nutrition, these are very, very important, and due to many of the anatomical abnormalities that occur. Health, general health is really important as well. So if somebody's having a lot of infections, if there are heart issues, if they're having multiple surgeries, these are all things that are very important for impacting growth. And finally, growth hormone deficiency can occur in some people with Charge syndrome. It doesn't appear to be everybody, but as far as I could tell looking through the literature, it might be somewhere in the realm of 10 to 15%, so about 1 in 10 perhaps, which is a small number, but it's still not trivial. So what can we do about it? And by this I mean if we have growth hormone deficiency or short stature. So firstly, we can optimize nutrition and health. As I alluded to, that's really important, and that can improve height growth right there. It's very important to monitor growth throughout childhood. An endocrinology evaluation may be indicated if somebody has short stature or if they're growing slowly despite optimizing health and nutrition. And at that point, the endocrinologist is going to be evaluating to see whether the individual might have growth hormone deficiency. How would an endocrinologist evaluate for growth hormone deficiency? So firstly, we would look at the growth pattern and take into account the factors that I've already mentioned. There may be some labs that are drawn, but then it usually ends up being something called a growth hormone stimulation test. So to remind you, the growth hormone is made by the pituitary gland in the brain. However, it's not made as a flat line, it's made as little pulses, as you can see here, prepubertal and pubertal. You can see little spikes, and that's how growth hormone is produced. So you can't just measure a blood test for growth hormone, because 90% of the time you'll get a level that's low in somebody who's making perfectly normal levels of growth hormone. So what we have to do is we do a test where we put in an IV. We give a medicine that stimulates the pituitary gland to make growth hormone, and then we measure growth hormone at intervals over about a 3-hour period of time. And then, depending on where that number falls, if that evidence supports the growth pattern to suggest that someone might have growth hormone deficiency. If somebody does have growth hormone deficiency, then the treatment of choice would be growth hormone therapy. And you can see here, this is how it's given. It's an injection, usually in a little cartridge by a small subcutaneous tiny needle. You can see here another of my patients, not with CHARGE syndrome, who's receiving a shot. So does growth hormone actually help growth in CHARGE syndrome? And looking through the literature, this was one report here of a case, a person with CHARGE syndrome who was started on growth hormone for growth hormone deficiency and followed all the way through life until they stopped growing as an adult. And you can see, hopefully you can see, these small dots where before growth hormone was started, the dot was below the bottom of the normal range. And you can see that over time, around age 4, it fell even further below the normal range. And then here you can see where growth hormone was started, and then growth increased. So this patient had catch-up growth close to the normal range, and then grew at pretty much a normal rate at the low end of the normal range from there. Actually grew to become a height that was within their target height based on their parents' heights. This is another study that I found in the literature. One of the growth hormone companies had reported data on their patients who had CHARGE syndrome who had been treated with growth hormone. And basically, the bottom line is that growth hormone does improve growth, although this is shorter term data. So what you can see here, it's a different way of looking because it's been standardized for age. So this line, this horizontal line is the average height with age corrected. This big bold red line is the bottom of the normal range. And this is when growth hormone was started. So you can see that this box was way below that red line. This is at 1 year, where you can see this box has actually climbed up closer to that red line. And then this is at 2 years, where that box is almost touching that red line. So essentially the bottom line is that growth does seem to improve in patients with CHARGE syndrome. Many of these patients in this study did have growth hormone deficiency, although a few did not. Are there some other benefits from growth hormone? So I'm going to list a few other benefits that growth hormone offers, and these are mainly seen in patients who have true growth hormone deficiency and have not really been studied specifically in CHARGE syndrome. Oops. So growth hormone may help improve muscle mass and strength, once again, in people who have true growth hormone deficiency. It may decrease body fat, and it may help improve bone density. Are there some downsides to growth hormone? Well, like I said before, it is a daily injection, so it's burdensome in that respect, although it is a very small subcutaneous injection. No medication is without side effects, although I would say it's well tolerated in most people, and the side effects in the patients who've been treated with CHARGE syndrome who have been reported in the literature seems to be pretty similar to other patients on growth hormone. I would say one thing that may be a little more pertinent in this patient population is that people with CHARGE syndrome may be at increased risk for developing scoliosis or a curvature of the spine. There is a report in the literature about some patients who did develop scoliosis. So growth hormone does not cause scoliosis. However, in any patient who has an underlying scoliosis or a predisposition, if they do have more rapid growth, they may be at higher risk of bringing that out a little more or exacerbating it. It's not a reason to not treat with growth hormone if growth hormone is indicated. However, it is just a red flag for saying, you know, the interdisciplinary or multidisciplinary care is very important, that this is something that would need to be assessed before starting growth hormone and monitored carefully during treatment. And then, of course, it's a very expensive medication. It is usually covered by insurance for people who have growth hormone deficiency. Oftentimes, it's not covered by insurance if growth hormone deficiency is not documented. So moving on to the G in CHARGE syndrome, genitals and puberty. And just to give you a reminder, so in terms of the sex hormones that come from the endocrine system, to remind you that the pituitary gland makes those controlling hormones, but even above the pituitary gland in the region called the hypothalamus in the brain, there's a hormone called gonadotropin releasing hormone. So this is like the top puberty controlling hormone. And then the pituitary gland makes a group of hormones. These are, again, the puberty controlling hormones. The medical term for these, and I hate bringing in big words, but I think some of these you may be familiar with your reading about CHARGE syndrome. So this group of hormones that control puberty from the pituitary gland are called gonadotropins, and these have really long names as well. We typically just call them LH and FSH. These are the hormones that stimulate the testicles in boys to make testosterone, and that's the hormone that brings about the male puberty signs that you're familiar with. And in girls, these hormones stimulate the ovaries to make estrogen, and this is the hormone that brings about the changes like breast development in girls. I want to just highlight the fact that this hormone controlling puberty is not just active at puberty, but that typical sex development actually starts before birth. So these hormones are at play even before the baby is born, typically around the 3rd trimester in the later part of pregnancy. So once again, the hormones, the gonadotropins, the puberty controlling hormones from the pituitary gland, acting on the testicles and ovaries even before the baby is born. You're getting those sex hormones, testosterone and estrogen, and these are very important for how the genitals appear when the baby's born. In particular, this is very important in boys. You don't really see as much change in girls, but in boys, both the gonadotropins, the hormones from the brain, as well as testosterone, the sex hormones, are very important for things like the testicles descending, as well as the growth of the penis in the later part of the pregnancy. And then, of course, later on, you have the sex hormones produced to bring about the changes at puberty that, again, you're all familiar with. So what happens in charge syndrome? Just taking you back to this pathway again. So you may not be making enough, if any, of the gonadotropin releasing hormone. This is the one, just to remind you, that's very tied in with the development for the nerves governing the sense of smell. In turn, or directly, you may not be making enough of the gonadotropins, the puberty-controlling hormones from the pituitary gland in the brain. And in turn, because you're not making those hormones upstream, you have low levels of the hormones downstream. So you have low levels of testosterone, both in utero as well as at puberty, and low levels of estrogen. And this gives rise to, and I know you've heard this term before, hypogonadotropic hypogonadism. So hypo means low. Hypogonadism means low functioning of the gonads, in other words, the testicles or the ovaries. And hypogonadotropic means low levels of those gonadotropins from the brain. So when you see that long word, hypogonadotropic hypogonadism, it means that you're not making enough puberty hormones, but the source of the problem comes from upstairs, not downstairs. So in charge syndrome, what do you see? At birth, you're going to see in boys, as I've alluded to, underdescended testicles if you don't have the hormones that bring them down during that last trimester. You may have a small penis, which is known as micropenis, and that's if you don't make enough testosterone to increase the size in the third trimester. And in girls, you may have underdeveloped labia, the lips of the genitals, but really most people aren't going to notice anything obvious. And then at puberty may be delayed, or it may not occur at all, or it may occur but may not go all the way. And later on in adulthood, there are other issues, such as the question of fertility. So how do we recognize hypogonadotropic hypogonadism, or HH, at birth? So the most obvious way is just a genital exam in boys. Typically, it's not picked up in girls, as I mentioned. And then we have one other little window of time that it's just important to be aware of. And this is called the mini-puberty. And somewhere between 2-3 months of age, babies actually make a surge of those puberty hormones. And you can see here on the graph, you have this surge where those hormones actually go up to puberty levels for a very short time. And then the levels go down to very low levels all the way through childhood until puberty, when they kick in again. So if you are alerted to the fact that this could be hypogonadotropic hypogonadism, you actually have a window of opportunity to measure those sex hormones around here to see whether they are within the normal range or low. If we miss that window, how would we recognize hypogonadotropic hypogonadism at puberty? So in girls, the very first sign of puberty would be breast buds that occur around the age of 10 on average. And if we're not seeing any sign by 13, when the late bloomers should have bloomed by then, that would be considered late. Or for periods, the typical age would be about 12 and a half. And if we're not seeing any periods from about 15, that would also be considered very late. In boys, the very first sign of puberty is actually when the testicles start to grow, and this starts to occur around the age of 11 and a half or 12. And if we're not seeing any sign of that by about the age of 14, this would be considered late. And these would all be red flags where you should be seeing a doctor and potentially an endocrinologist if you haven't already seen one before. So there's one other clue to recognizing this issue, and it's to do with the sense of smell. So if you remember, I said that the nerves that actually make the hormones in the hypothalamus, that are the hormones that control the whole puberty process, the development of those nerves is tightly tied in with the development of the nerves that control the sense of smell. And so it's actually been shown in people who have charge syndrome that lack of the sense of smell or doing a smell test can actually help predict hypogonadotropic hypogonadism in people with charge syndrome. And another way of sort of looking at the same thing would be if somebody has had an MRI, and if that MRI has captured the part of the brain with what's called the olfactory bulbs, so that's the part of the nerve, again, that controls the sense of smell. And a lot of the time in people with charge syndrome, particularly if they have a problem with the sense of smell, may have underdeveloped or even absent bulbs. So if you see that on an MRI, or if somebody thinks about doing smell testing during childhood, these can be red flags of being quite predictive for having hypogonadotropic hypogonadism when puberty comes along. So how would we evaluate this? Well, we can measure the sex hormones. As I said previously, we can measure them during that mini-puberty time, or we can measure them during puberty. We can also do something called a stimulation test, trying to measure the hormones from the brain. And here we would give this upstairs hormone as a medicine, and we would measure these hormones, the gonadotropins, in turn. So it's a little bit like that growth hormone stimulation test, but we're just giving a different medicine and measuring different hormones. Sometimes we'll do an X-ray of the hand, and this is looking for something called the bone age. And this is one way of telling us how old the body thinks it is, rather than just what our age is depending on our birthday. And somebody who's not gone into puberty, their body may think that they look more like 8 years old rather than someone who's 12 years old. So it's something that we do to assess people who have delayed puberty and slow growth. So what can we do about it? Well, first of all, in babies, and remember it's really more pertinent to boys at this age group, we can give hormone injections. So we could actually give a short course of testosterone early on, and that can mimic that mini puberty and help the penis grow. We can also give a hormone called HCG, and that is just like the hormone that comes from the pituitary gland, and that may or may not help the testicles to come down a little bit, but a lot of the time people who have undescended testicles need to have a surgical procedure just to bring those down. The goals of treatment are to try and bring the testicles down, because that's actually important for things like the possibility for fertility in the future. It's also important for preventing any kind of growth in the testicles down the road. And of course, the other goal is having the penis to grow to look more like a normal size. What can we do about it at puberty age? So in boys, once again, we can give that puberty hormone, testosterone, and this can be given either as a shot once a month, or it can be given as a daily gel on the skin. In girls, we can give back estrogen, and this is given either as a patch, as you can see here, or a pill. And in general, we actually tend to favor treating with a patch because we can give it in lower doses and in much more natural type of doses because it's absorbed straight through the skin into the bloodstream, whereas when you give a pill, it has to go through the gut, into the bloodstream via the liver, and then into the bloodstream after that to bring about its actions, and so you may have much higher levels. There's also been some evidence to suggest that giving it as a patch may be more beneficial for your bone health rather than giving it as a pill. Later on in puberty for girls, another hormone called progesterone is added, and this is what helps the uterus shed and have a period. We typically start low and slow, and we're trying to mimic what happens in normal puberty when it's happening naturally. And so we start with a tiny dose, and then the doses increase gradually over about 2 to 4 years or so. And I put this with a question mark. Should we be starting at an appropriate age? If we're certain of the diagnosis from some of the clues from early on, there could be an argument for suggesting we should be starting at an age-appropriate time, which may also help just with things like social adjustment, in addition to all the other issues that people with CHARGE syndrome may face. There may be some argument in terms of developmental maturity as well, so there's many different factors that have to be taken into consideration. The goals of hormone replacement are firstly to induce sexual characteristics. So for boys, that's growth of the penis, body hair, deepening of voice. For girls, that would be breast development, growth of the uterus, and development of the lining of the vagina. And the progesterone matures that uterine lining and brings about periods. It's also important, possibly, for sexual function, although I'm sure that's bottom of everybody's priority list for their children growing up. It's very important for a growth spurt. So puberty hormones actually help you grow faster during puberty. But the other thing that's important to realize is that over time, the puberty hormones close the growth plates, and so by the end of puberty, you stop growing. So if short stature, for example, is a concern, there may be an argument for actually starting those puberty hormones a little bit on the later side to buy more time to grow before you start to close that window of available growth. Or you might decide to increase the dose of the puberty hormones slower to allow more time to grow. It's important, as I mentioned before, for bone health, in boys for muscle mass and strength, and may help with a better metabolic profile. And of course, not least, it's very important for psychological or psychosocial adjustment and well-being. What are some of the downsides? Because everybody freaks out about starting puberty hormones, and of course some of the things that people think about for estrogen might be, does it increase the risk of blood clots? But I think the risk would be extremely low in teens. That tends to be more of a concern in older people. However, it is important to know if there's a family history of blood clots. It might increase your mood swings, but again, that could be argued as part of normal growing up. And then this one always flips people out. What if my child has a period? I'd rather not have to deal with that in addition to everything else. What about boys? So higher doses of testosterone may increase your blood count, so that's something that typically is monitored for people on adult doses. May increase acne, but again, you could argue that's part of normal puberty, and I had one boy, not with CHARGE, who told me that he was actually quite happy to get acne because that made him feel like his friends finally. And then, you know, perhaps it might also exacerbate mood swings, but I would argue that, you know, mood swings and behavior are more complex than just the hormones. So then thinking about those downsides, do we even want to treat? And I would make the case of saying, you know, treatment has to be individualized. There's not necessarily one right time to start treatment or one right way to do it. However, I think that it's important to be proactive in the decision. If we decide we're going to hold off puberty because of growth or because of developmental issues or other health concerns, then that should be a proactive decision as opposed to just an inactive decision. What about some options for managing menses? You know, it's not as bad as everyone necessarily thinks it is. For someone who's having natural puberty, one option would be just letting nature take its course, see how it goes, depending on the individual, of course. So if you're on birth control patch or pills, there could also be the option of extending the cycle. So rather than having a bleed every month, you can actually manipulate how often you have that bleed, and you can stretch that out every 2 to 3 months or so. Or for some people who have special needs, an intrauterine device can be placed under anesthesia. That's a tiny little thing that just sits inside the uterus, and it sits there for about 5 years. And it basically prevents the lining of the uterus from building up. So you're still getting the benefit of the estrogen hormone, but you're not getting that buildup in the uterus that has to bleed and have a period. So it can basically switch the periods off. So what are finally some other endocrine issues faced by people with CHARGE syndrome? So bone health, as I already mentioned, and this is a case report that I found in the literature, a young man from Ecuador who presented for the first time when he was 29 years old. And basically he had many of the features of CHARGE syndrome. He was completely prepubertal, but the other thing that was, concerning was that he had severe osteoporosis. So it's really just a reminder that even though we don't typically think about bone health issues when our children are younger, there's still an important thing to factor in terms of holistic care. So what can we do? First of all, addressing the hypogonadism with sex hormone treatment, as I've mentioned. If somebody is growth hormone deficient, then growth hormone replacement may also contribute towards better bone health. Good nutrition is very important for all of us for our bone health, including adequate calcium and vitamin D. And our best source of vitamin D, as you know, is from the sunshine. And then finally, where able, weight-bearing activity also helps promote bone health. Some of the other endocrine issues that can also occur in CHARGE syndrome, as I mentioned at the beginning, some people have been reported to have structural abnormalities of the pituitary gland. Some people have been reported as having low thyroid levels, and some people have been reported as having low cortisol levels or adrenal insufficiency. Low thyroid, this is something that is not that common in CHARGE syndrome, but it's still important. It's something that we need to think about if someone is not growing well, gaining weight. It can affect metabolism, it can affect temperature regulation, and it can just affect our energy and general well-being. If there are any clinical concerns, we would want to check thyroid levels, and that's a very easy blood test. And then if someone's found to have low thyroid levels, the treatment is also very easy. It's just a pill once a day. Adrenal insufficiency is also something that is quite uncommon. There is a little bit of literature on this in CHARGE syndrome, but I don't think it's been that conclusively studied, to be honest. So the adrenal glands are little glands that sit on top of our kidneys. They make some hormones, and the important one here is cortisol. And cortisol is important for various things. Just for staying alive, if your body's not making cortisol, basically that's not compatible with life. It's important for recovering from infection, also for recovering from anesthesia. It's important for maintaining our blood sugar and also giving us strength and energy. There have been 3 reports of patients with CHARGE syndrome who have adrenal insufficiency that have been confirmed, although there was also a report where there were a few that I questioned the diagnosis a little bit, and I would just say I don't think this has been conclusively studied. Having said that, I don't think it's necessarily common in everybody with CHARGE syndrome. However, I think it is important to think about and consider, particularly for people who might have structural pituitary abnormalities or other pituitary hormone deficiencies, or if there are any other symptoms that would alert. For example, if we've had a surgery and we've had poor recovery or low blood pressure following a procedure where we've needed some additional help that's over and above what would be expected, then I think this is something that would be very important to think about, because not treating this could be life-threatening, even though it's not that common. So just to start wrapping up here, there was a CHARGE syndrome checklist that was published a couple of years ago with a list of many of the different features of CHARGE syndrome that should be addressed across the lifespan. I have modified this to tailor it more for the endocrine system. So at birth, we have to think about hypogonadotropic hypogonadism, and we should be thinking about checking those puberty hormone levels around 2 or 3 months of age, and also considering whether or not a surgical procedure is needed to bring those testicles down in boys. In childhood, we need to be monitoring growth, and an endocrinology consult may be indicated if we have short stature and slow growth, particularly if we've ruled out other causes, to check for growth hormone deficiency and see if growth hormone is indicated. At puberty, we need to be considering an endocrinology consult to see whether hormone replacement treatment is needed. And then finally, puberty and transitioning through adulthood, other things to think about are bone health, excessive weight gain, which we haven't really talked about today, and later on, possible reproductive issues. So where are we today and where are we going in terms of just our care for Charge syndrome in general, but also for our care of endocrine issues in people with Charge syndrome? Are we inactive? And I'm sure that nobody here in this room would fill that bill, where we would have someone presenting at the age of 29 for the very first time with no sign of puberty and osteoporosis. Are we reactive, finally going to the endocrinologist when we absolutely have no choice, when we finally have to? Or are we proactive, thinking about clues early on in childhood that could alert us perhaps to starting hormone treatment in a timely fashion if that's appropriate for your child? So finally, back to Adam. Adam communicates, I'd say, reasonably well with his iPad, but I'm sure that if he were verbal, he would be saying, along with me, that firstly, endocrine issues are very important in Charge syndrome, in people with Charge syndrome. That endocrine care can actually help improve health as well as psychosocial adjustment in people with Charge syndrome. We would recommend early involvement with an endocrinologist. Doesn't necessarily have to be an endocrinologist here, it could be someone close to home. And I think we all agree that people with Charge syndrome deserve coordinated proactive care, and that care should include endocrinology. Thank you.